have a wife of 21 years and two sons who are 15 and 11. And they're sort of passionate musicians. And I think they get some of that from me. I'm very much a music buff. And so we do music together. And besides hanging out with my family, I have a very close group of friends that actually started as a poker game and evolved over the past 15 years that I've lived here in Gainesville into, we still call it the poker group, but we go to movies together and we go out to dinner, and we've actually turned it into a travel group. When we moved to Gainesville, we didn't know a soul here. I came from Salt Lake City with my wife and 4-month-old baby. And I was at the time an intern, so I was working, 130 hours a week. So I was essentially absent, and my wife and our 4-month-old son had to fend for themselves. And it was a struggle for the first couple of years, and little by little, we built this amazing support group. I was drawn to the University of Florida neurosurgery program in the beginning because when I was in medical school, the University of Florida was one of the top neurosurgery training programs in the world. And the chairman of neurosurgery is still one of the most famous neurosurgeons still alive, Albert Roten. What kept me here was the environment. I'm very much a people person. Everyone here is pretty open and pretty relaxed. And there's a camaraderie here that I haven't felt in some other places. So, it's a team that I feel a part of. I have a partner, Mike Okun, who is a neurologist. We both study the brain and the central nervous system, but we come about it from a different perspective. And what I do, my specialty in functional neurosurgery, and especially deep brain stimulation, is critically reliant on effective interdisciplinary care. Michael Okun, my neurology partner, was a close friend of mine before we became partners. He was a resident here in neurology while I was a resident in neurosurgery. We went away and did our fellowship training. I went to France and studied with Professor Benabid, and he went to Emory University to study with Drs. DeLong and Vitek. And then I came to Emory and spent a few months studying neurology at Emory. He studied neurosurgery at Emory as well during his 2-year fellowship there. And we joined there and came here to start the deep brain stimulation program at the University of Florida. So we may be the only neurosurgery neurology team where the neurologist has neurosurgery training and the neurosurgeon has neurology training. And we both sort of train together. So I think we share sort of a common notion about how things ought to be. The team that started with me and Mike Okun and one physician's assistant is now, I think, 70 people. And it's a huge interdisciplinary group of people who focus on Parkinson's disease and other movement disorders. And we've actually become fairly well known for our interdisciplinary approach, very patient-centered, and we all try to answer the same questions about the patient, but from a different perspective, with different expertise. So we pull in the physical therapist who specializes in Parkinson's disease, the occupational therapist, the speech therapist, the swallowing expert, the social worker. There's a whole cadre of people with different expertise, and our method is for everyone to focus on this one patient together at the same time and communicate about this case and then come up with a recommendation, and it's proven very powerful. Here at the University of Florida and Shands Hospital, the multidisciplinary team that we've put together for the deep brain stimulation program is, in my experience, unparalleled. We host visitors, visiting physicians, and visiting administrators from other hospitals, from all around the world, frequently, to come and see how we've put this program together, because it's very patient-centered and it's very effective. There's a 95% versus 85% rule when it comes to deep brain stimulation, and that is, deep brain stimulation is a really great procedure, and if you do it poorly, 85% of the people who have the procedure are still going to do well. But if you do it very carefully in this multidisciplinary way that we think is a better way, we think we can get 95% of the patients to do very well. And we've studied that, and our statistics bear it out. So, we've been pretty pleased with the outcome of this effort. I've done 600 deep brain stimulator implantations, and if you ask me, am I better at it now than I was when I started? I'm dramatically better at it. I know all the things that can go wrong now. And now I tend to operate thinking about all the different things that I've seen go wrong because of this move or that move, or because you put the stitch in this way or that way. And so I have a very methodical, step-by-step way of doing it that I've developed because of that experience. The patients that we see for deep brain stimulation, the most common patients are patients with Parkinson's disease. But we also do deep brain stimulation to treat people with disabling tremor, to treat people with problems like dystonia, involuntary muscle contractions that make it so they can't move the way they want to move. And more recently, we've been doing a lot of research-oriented deep brain stimulation, experimental things, looking at deep brain stimulation to treat disabling psychiatric disorders like obsessive-compulsive disorder and Tourette's syndrome and depression. And right now we have several NIH-sponsored studies looking at different ways to use deep brain stimulation to affect these disorders that are caused by malfunctioning circuits in the brain. And if we can identify where the circuit in the brain is malfunctioning, we might be able to modulate it or manipulate it with electrical stimulation. And we've been dramatically successful in Parkinson's disease and with tremors and with dystonia, and now we're sort of moving on to other disorders that we understand. We don't cure Parkinson's disease with deep brain stimulation, but we get people with Parkinson's disease who are profoundly disabled into their best functional state and keep them there much more of the time. So it's not a life-saving procedure, it's a quality of life-saving procedure. It's amazing to have that sort of impact on someone's life. And, my movement disorder patients are some of the most gratifying patients to work with because, they're not dying, but they're suffering. And frequently when we finish working on them, they're not suffering anymore. And it's fantastic to see someone who couldn't walk before who can walk now, because these are folks who haven't signed a check for 10 years because they can't write, they can't feed themselves, everything is done for them, they can't button their own clothes, that sort of stuff. And they go in the space of 3 hours of a procedure from profoundly disabled to able to do all that stuff again. So, when I give lectures about this, I show before and after videos, and the line that I typically use is, how cool is my job? and everybody can appreciate it when they see the before and after. It's a lot of fun.